Hi, everyone, and thank you for joining us for tonight's webinar presented by Aspire Respiratory Products. This webinar is entitled Back to the Basics, an overview of respiratory anatomy and physiology. And I am so happy to welcome my colleague and friend, Dr. Rich Severin. He is an internationally recognized speaker, researcher, author, and professor on the topic of respiratory muscle strength training. In fact, Dr. Severin actually wrote the section on RMST for the American College of Sports Medicine guidelines. So we're very lucky to have him here today. And hopefully today's webinar will add to a comprehensive knowledge base for those of you using RMST in your practice, or at least be a nice refresher. We strongly feel that in order to apply and adapt this intervention appropriately, understanding where it's rooted is important. I will ask you to please hold your questions until the Q&A section at the end of the presentation, and it will be recorded and available on demand. Dr. Severin, the floor is yours. Thank you so much for being here. We appreciate you.
Great. Thanks so much, Jenny. Well, welcome everybody. Super excited to give this talk to you guys. I appreciate, you guys logging in on a Wednesday, evening in the holiday season to learn about some physiology. So the title of this course, again, is Back to the Basics, an overview of respiratory anatomy and physiology. Hopefully this is a lot of review. We'll have some time maybe at the end if people have questions and stuff like that. Some disclaimers. Obviously, I teach courses on respiratory muscle testing and training, both for my own personal company, PT Reviewer, and as well as for Aspire Respiratory Products, where I am the scientific and clinical expert consultant. Do product testing for a lot of other companies as well too, which I have those listed. This won't really be too meaningful in terms of my conflicts or disclaimers, but just the full disclosure. And if you ever are interested in learning more, I have got a pretty robust social media presence, so you can find me on those things. It's all PT Reviewer, even on YouTube, Instagram. It's PT_reviewer. Still looking for the person who got that beat me to the punch on that one. But you can find me there and I frequently post stuff about respiratory muscle testing and physiology. So the goal of the day for objectives, identifying key anatomical structures, and we're going to unpack some terms or phrasing or how we categorize certain muscles as well too. We'll go over the physiological mechanisms that kind of generate inspiratory and expiratory pressures, how they act on the lungs and the pleura, and then we'll get into how respiratory muscle performance influences respiratory function. We'll talk about as well some case examples of how different factors that affect the work of breathing can affect the force generating capacity, or basically the load against the breathing muscles, which will kind of tie into the objective 4. So without further ado, I guess we'll begin. So some things to kind of unpack here when we're talking about breathing, kind of the umbrella term for what we're doing. There's actually two separate components. There's ventilation, which is the movement of air in and out of the lungs and airways. And then there's respiration, which is the diffusion of gas across the alveolar capillary interface. These terms will all be used kind of interchangeably. They are kind of somewhat synonymous to each other, but they are actually different things, as we've alluded to. So when we're talking about the breathing muscles, we're really actually technically talking about ventilatory muscles, because they really primarily act by acting on the rib cage, which generates the pressure to allow air to flow in. They indirectly affect respiration. That's really more perfusion, and then volume of air as well. So I'll probably use these interchangeably today, but just remember, we're talking about two separate kind of constructs: ventilation versus respiration. So the muscles of the ventilatory pump, okay, these contract rhythmically and intermittently throughout life, from our very first breath to our very last breath. And in fact, we find that we're practicing kind of the neural pathways for breathing even in utero. We're finding this, a few weeks even before we're actually going to use them. So this is something that's very hardwired, and we'll go over some of the neural control of breathing later on and what goes into it. Now, the great thing is probably what made me so interested in these muscles. They operate both under voluntary and involuntary control. So you can take deeper breaths if you want to, right? Voluntarily. You can take smaller breaths. And then they obviously have that baseline running of involuntary control. We don't have to think about it, fortunately, but we can have a lot of flexibility in meeting demands. Now, the key thing, we'll get into this later on, that the breathing muscles don't really work against gravity in the common sense that we think about it. They primarily work against airway resistance and elastic recoil forces. And we'll get into more than that. We talk about the work of breathing and what that entails. But they don't work against gravity. That's kind of a key thing to think about. It's a little different than like other muscles if you think about it that way. So they work against slightly different forces. Now, we've got two general groupings of muscles. We have our inspiratory muscles and then our expiratory muscles. And for inspiratory muscles, we're referring to primarily, the diaphragm, which is about 75 to 80% of the inspiratory effort at rest. Now, that's important to note. We'll get into that later on. At rest, during exercise, it changes. We have our intercostal muscles, basically the rib meat that attaches to our ribs, our accessory muscles, which are scalene or sternocleidomastoid and pec minor. Now, uh, I'll have these later on in quotations and in italics about the accessory muscles, because as you'll learn later on, like that's a bit of a misnomer. They're actually pretty important, and in fact, they're muscles that we consider accessory. Actually, some of them are electrically active the entire time. In fact, notably, the parasternal muscles and our scalenes are actually crucial for that upper displacement of the ribs and chest wall during breathing. So they're actually always on. And then expiration under resting conditions is primarily passive. It's mainly that recoil of the lung and chest wall complex, and then return of the diaphragm. But that changes during exercise when that becomes more of an active process using abdominal muscles and some of those intercostals too. So again, we often think of breathing through a lens just of what occurs, at rest, but obviously we use these in different contexts, notably exercise and coughing, where the role of these muscles, the contributions of these muscles, and even just the energy use, completely changes. So again, think of it kind of contextually. I think of it analogous, almost kind of what we do with running. That muscles that we may use during walking gait is a little bit different than the muscles we use during running gait. It's kind of the same idea. So now, again, I have this up here that looking at those muscles of the ventatory pump under quiet, normal breathing, I got a nice graph to kind of illustrate what I'm kind of alluding to here. The diaphragm is the primary contributor to ventilation. It's a primary muscle, about 80%. But again, those accessory muscles, again, things we think of like as accessory muscles, are always some of them are always active. Again, like the scalenes, the parasternal or intercostals are always active and actually very necessary. And as we begin to exercise, as demand increases, the contributions of those muscles also increases. So I think the term accessory is a bit of a misnomer because that kind of makes them seem unimportant or an afterthought. They're actually really important for exercise responses. And we look at trying to operationalize like what's normal patterns of breathing. Just think that the note too that if you look at like individuals across a normal healthy population, diaphragm motion is actually pretty variable. And we'll get into that too, variability of the pattern of breathing. And that, we often have this idealized view that, you got to have this big belly excursions, which, can be helpful in some contexts, but, it may not be the best pattern to be using during exercise. And we'll kind of get into that as well too. Because again, we sometimes we need those accessory muscles as well. And we'll get into this later on. So again, looking at the muscles, kind of we're talking about, diaphragm as it contracts, it distends down. And we see an increase, right, in thoracic volume, which increases pleural volume, which decreases the pressure surrounding the lungs, allows them to expand, drops pressure in the alveolus or the lungs, and air is able to flow in. So this is just illustrating kind of the general kind of action of these muscles. Now, this is, I think, a really important slide here. If you look at, again, under resting conditions, which we often is the only way that we typically view these muscles. If we only view the contributions of these muscles under resting conditions, we're completely missing their contributions during exercise, where demand increases. So we'll kind of go through this. So if we look at rest, let me get my pen here. This is a chart here, and it's actually a great paper by Aliverti in Breathe, which is one of the European Respiratory Society journals to open access. I highly recommend checking this one out because it details what we see in terms of different contributions of these breathing muscles as we move from resting conditions here, okay, to maximal exercise, okay, maximal exercise. So at rest, the diaphragm, okay, is primarily a pressure generator, okay? Pressure generator meaning it creates that initial gradient of pressure for air to flow in. Okay, it's that negative or lower than the atmospheric environment to allow air to flow in, right, into our lungs. The rib cage muscles also are pressure generators as well. And the abdominal muscles are generally not active, right? They're not really doing too much because, again, expiration, which is where the abdominal muscles kind of kick in, it's just recoil under resting conditions. There really is no active muscle activity going on with expiration, so the abdominals are kind of quiet. This changes, okay? This changes when we begin to exercise. The diaphragm becomes primarily a flow generator, meaning that it's primarily going to be influencing the volume and the rate by which air begins to flow in and out of the lungs. It's a flow generator, okay? So its role changes. And then we've got, thanks, Jenny, great. And then we look at our rib cage muscles. These actually become the pressure generators for inspiration. And then we start seeing abdominal muscle contribution as we begin to exercise because we have to move more air in and move more air out. And that becomes a very active process. And this continues on, right, as we begin to exercise at higher intensity. So what this is saying is that, again, if we only view breathing from a resting conditions, we're going to completely miss the importance of these other muscles. So again, just kind of really just illustrates that these this concept that that the accessory muscles are kind of unimportant or vestigial is kind of a misnomer. They're really important again. So again, at rest, the diaphragm is primarily a pressure generator. During exercise, becomes a flow generator. That means its mechanical power is mainly expressed as the velocity of shortening rather than pressure. So its role becomes more again about moving that air in versus generating the pressures required to move the rib cage and abdomen respectively. So again, and that role, that pressure generation is going to primarily come from those, quote unquote accessory muscles and the abdominal muscle. So again, they're all important, right? Their contributions change depending on the task or demands of the task imposed upon them. And that's true for every muscle or every muscle group or any movement, right? We've got a multitude of muscles that contribute and their relative contributions change. Again, think of the walking analogy. When we begin to walk under basic locomotion, we don't have a lot of, our contributions, for example, of our hamstrings, right, or our calf muscles is going to be a lot different than what they would be during running, right? So another way to think about it as well, too. So the basics of ventilation, right? So this should be a bit of a review here to you guys. So we'll just kind of go over those four pressures and kind of how the breathing muscles kind of interact. So now it's always important to remember that your lungs kind of sit in this potential space called your pleura, okay, your pleural space or pleural sac, which is created because there's kind of a force couple or balance between the outward pull or the elastic recoil of the chest wall, which wants to pull out in this direction, okay, and then the elastic recoil of the lung. Remembering the lung, if you might remember from anatomy, is kind of springy, right? Because it has elastin fibers in it. And elastin fibers operate just like elastin, right? They want to kind of collapse upon itself, right? It's a tendency to want to pull in this direction, okay? Or you can think of it maybe in, in this direction if they're going to be opposite to each other. And that balance, that separation creates that pleural space, okay? All that really happens when we exercise is we slightly increase the volume in this pleural space, remains a closed environment, which decreases the pressure by increasing the volume. And that allows the lungs to expand. We'll kind of go through this step by step, but it's basically how breathing occurs, right? A drop in that interpleural pressure causes a drop in interpulmonary pressure, allowing the lungs to expand, pulling air into them, and then doing basically the same process reverses during expiration under resting conditions. And again, it's this pleural space actually crucial because if you lose this pleural space, or it becomes equilibrated to atmospheric, there's no ability to generate a breath. So the mechanics of breathing for inspiration. So in the relaxed state, diaphragm is dome shaped. The diaphragm contracts, it flattens and descends, increasing the volume of the thoracic cavity. As the thoracic dimensions increase during inspiration, interpleural volume also increases. You think the chest wall's moving away. And interpleural pressure becomes more negative. It always sits a little bit below atmospheric. Here, again, it typically sits around -4 relative to atmosphere. You can think of this here. Atmospheric is going to be about 760 millimeters of mercury, or this will sit at 756, so a little bit below. When we inspire, it becomes more negative, closer to like -8. This change in pressure pulls on the lungs as thoracic volume increases, and the lungs begin to expand because there's less pressure surrounding them, essentially, which causes the interpulmonary volume to increase, and then further decreases its pressure, and then air is able to flow in. So, air begins to flow in. Now, inspiration ends when thoracic volume ceases to increase, resulting in no further reduction in pleural pressure and interpulmonary pressure in the lungs. Gas flow ceases, lung volume doesn't change. And then during further or deeper inspiration, the volume of the thoracic cavities further increase. So you can all kind of estimate or can experience that when you take resting breaths, right? We have a volume we get to as we expand. As we take bigger breaths, right, the volume further increases, and we have a greater kick in of those accessory muscles that help act in the chest wall. Again, these muscles really aren't just accessory, they're context dependent. That's a way to think about them. Not accessory, they're context dependent, and they're very important. So again, just kind of going over that as well. Now, expiration, try just the opposite, right? During expiration, quiet breathing is typically, again, a passive process. This changes during exercise. Again, changes during exercise becomes more of an active process. But under rest, it's primarily the elastic recoil of the lungs, right? Again, we talked about them, right? They have those elastin fibers. When elastin, right, you have a coil. We can think of elastin as kind of as like a coil or a spring. When we stretch out a spring, right, we've increased the potential energy for it to want to return. Okay, so if you stretch out a spring, it's going to want to pull back. Okay, so once that happens, right, the elastic potential increases, and that causes a recoil back in. There's also a recoil of the chest wall, and then rather than active muscle contraction. So as the inspiratory muscles relax, the diaphragm reascends to its resting position, that dome shape. The rib cage descends, the volume of the thoracic cavity decreases, and the stretch elastic tissue recoils. All this together increases the pressure in the lungs higher now than atmospheric, and air begins to flow out because pressure always goes from high to low. That's how air flows in, because we decrease the pressure below atmospheric and it begins to flow into the lungs. During expiration, we increase the pressure higher than atmospheric and it flows out. Okay. And I got a couple graphs that will help kind of illustrate this. So again, just things to kind of bear in mind, these 4 pressures associated with ventilation. Again, atmospheric, it's going to sit about 760 millimeters of mercury. And we have our pressure, our interpulmonary pressure, which varies with ventilation. During inspiration, like I mentioned, it's going to be less than atmospheric. Okay. During expiration, it's going to be slightly greater than atmospheric. Okay. And at rest, when there's no airflow, alveolar pressure or pressure in the lungs, pulmonary pressure, is roughly equal. And if they're equal, right, there's no gradient, there's no flow. And again, we typically express this just as zero when it's equal to atmospheric because it's just easy to remember. So it's when it's expressed as zero, we're talking about zero relative to atmospheric, right? Interpleural pressure also will vary with ventilation, but it will always ideally stay negative because if you don't want this to go really above, right? So um, always less than interalveolar pressure, and it's always negative, right? And then all that happens during inspiration is that it becomes more negative, okay? And then we have a thing called transpulmonary pressure. It's another way to kind of conceptualize this. It's the difference between alveolar pressure and interpleural pressure. Generally, this should always be positive, which keeps the lungs inflated. But that's kind of even getting beyond this. But you may see this referred to as well. And that's a way to indicate whether the lungs stay inflated. And we'll illustrate this on this graph here. So, again, kind of going through this step by step. Remembering at rest, our interpleural pressures, right? Pressure in the pleura is going to be at roughly -5. And again, this is relative to atmospheric. All these values are relative to atmospheric, but ATM, not the bank, but atmosphere. Okay. All these are relative to atmospheric. Alveolar pressure, okay, and is going to be at roughly zero, okay, at rest. Okay, at rest. Here. Okay. Looking at pleural pressures, again, going to be at -5. Here. Okay. And then here. Okay. When you're at zero again, there's no flow, no volume change. Okay. As we begin to inspire, okay, again, we act on the chest wall expands. Okay. And that causes the pleura to become more negative. Okay. More negative, right? So it goes from -5 to -8. Okay. That allows the lungs to expand because there's the pressure below it's even low around it's even lower. Okay. And we start seeing alveolar pressure begin to drop. The pressure that's in the lungs drops, -1 relative to atmospheric. Again, if the pressure in the lungs is lower than atmospheric, air will begin to flow in because pressure goes from high to low. Atmosphere would be, 1 higher, than what's in the lungs. And that causes air to begin to flow and fill into the lungs. So this continues on, okay, until the end of inspiration, where our lungs are going to be the full as they will be for our normal breath. And all those things begin to relax. Now, what happens is, again, the pleural pressures don't become positive. Pleural pressures just go back to what they were, okay, at rest, which is around that -5, okay, because the chest wall is beginning to recoil. And the lungs, remember, are still more full. So with that filled lung, with the chest wall recoiling and the lungs recoiling, that causes the pressure to go up a little higher now than alveolar pressure because we're basically, starting empty, filling. Pressure goes up as they recoil. Pressure just goes slightly above now. Atmosphere +1. Okay. That's going to be higher than atmospheric. And then air will begin to flow out to the lungs. So all we're really doing by using the breathing muscles is just changing the relative pressure in the lungs slightly above or slightly below atmospheric, okay, to create a pressure gradient to let air to flow into the lungs. And it's important for that pleural space to be there because that's what allows that expansion and contraction. and it has to remain negative because if it ever becomes positive, we're going to have compression of the lung. That's not a good thing, or pneumothorax. Now, it's also important to note the energy demands or pressure demands are pretty low. If you think about it, under normal compliance, healthy lungs, normal elastic recoil forces, we're only having to generate relatively about like 5 centimeters of water to bring in a normal tidal volume, which is about 500 milliliters for each person. So as read on in our other lectures about respiratory muscle performance, the breathing muscles typically can generate around 100 for a healthy, middle-aged person, around 100 centimeters of water. So we operate at a very high efficiency rating, which is very good because we do this process from our very first breath to our very last breath. So we want to operate very low to our, or much lower than our margins. So we're very, very efficient at breathing is what this is illustrating as well too. Another way, just kind of again illustrating this differentiation between gradients in breathing. Now, coughing, another thing that's also very important that the breathing muscles kind of contribute. Now, coughing, you can think of it in 3 phases. My speech language pathologists who are on the call can probably even break it down maybe even further. But we think of it often three phases. You have an inspiratory phase, a compression phase, and then an expiratory phase. Okay, so the crucial element of a cough is generating enough volume to pressurize to force things out. So you need to be able to generate enough volume. That's where respiratory muscle performance comes in because you don't have strong enough muscles that act on that rib cage. You may not be able to generate a big enough volume at the start. That's where certain other techniques can come in, stacked breathing, assisted coughing techniques, stuff like that. But first phase, we generate that initial volume, fill the lungs as much as we can. Then we have a compression phase, right? So we're basically filling our kind of bellow as much as we can, and then we begin to compress and increasing that pressure as much as we possibly can, right? To create a gradient behind the glottis to where we have the expiratory phase where it opens, we can push out that whatever's lodged in our upper airways. So again, we generate enough pressure, generate enough volume, right? We compress it, build up pressure, and with a closed glottis, we have compression of the airways of the chest wall, builds pressure. So we have the glottis open, and then we expectorate or push out that whatever was lodged in as a cough. Okay, and I think this kind of this what we're seeing here, looking at this image here, this kind of this graphic here. We've got again that initial volume in inspiration, okay, compression. Again, we fill the lungs. Now we're starting to squeeze down and building pressure, okay, and then with a closed glottis, that's kind of the critical thing. The glottis has to be closed, keeping that kind of seal as we pressurize that volume. And then when the glottis opens, this high pressure can shoot out what was ever lodged in the air here. So again, coughing really important for those breathing muscles, both inspiratory and expiratory, because coughing, right, is going to require that forced expiratory effort. It's also important for inspiratory muscle effort because I have to generate enough volume, right, initially by that is muscles acting on the chest to increase the volume of the chest. And then for compression, again, for those, expiratory muscles. Now, we'll get a little bit into the neural control of breathing. Another thing I think is kind of important to recognize, again, just thinking about how many different things go into controlling breathing. Again, and this is something that we are kind of hardwired to do. We've been doing again since even before we had to. We've got obviously primarily, processing, inputs from our chemoreceptors, both centrally and peripherally. There's also lung stretch receptors. There's also mechanoreceptors and the muscles that contribute, and they all get processed within our hypothalamus. Automated process um, to match breathing to the demands imposed upon the respiratory system. We can also have voluntary control as well. Again, let me talk about that dual role of the breathing muscles, which I think is kind of unique because there really isn't a muscle out there that just operates completely involuntarily at baseline, and then you can also have volitional control too. So I think it's one of the coolest things about the breathing muscles. So um, now you've got your DRG and your VRG. Your DRG is located within the nucleus solitarius tract, situated in the dorsal portion of the medulla. Basically, this is kind of the signal processing center where it receives sensor inputs from all those different areas, and it processes them and sends out signals that eventually make it down to the breathing muscles. And we'll talk about kind of where it goes down to. So the DRG is the main kind of sensory integration process, right? Where it receives all the sensory inputs and then processes them out into a motor output. You can think of it as the signal kind of receiver in a certain sense. And then you've got your VRG. The VRG is kind of like the relay switch, okay, of a switchboard operator. So the DRG receives things, the VRG projects out to the pre-bots and then the bots. We'll talk about what those are later on. Now, during quiet breathing, the VRG is kind of inactive. It's just a relay switch. It doesn't really do a ton. This changes during exercise or situations where the demand may increase a little bit, actually. Okay. But again, primarily just a relay switch that sends those signals from the DRG to those downstream to the pre-vascular complex. So we've got here as well, our pre-bots and then our Bottinger. Okay. And the pre-bot contains those inspiratory neurons. Okay. It functions as a primary respiratory CPG. It sets kind of the baseline. It's the baseline pacer, right? That goes out as projections through the breathing muscles. It can augment its output based on input from the DRG. When there is greater demand, the VRG will start turning on more switches kind of in the switchboard. And then you start seeing greater activity by both the pre-bots and the Bottinger complex. The increased activity of both inspiratory and expiratory muscles. So what this is basically saying is you've got integrating center in your DRG. You've got a relay switch basically of your VRG, which act on your pre-Bottinger complex, which is kind of the baseline rhythm, baseline CPG, which goes out to the breathing muscles. Under rest, it's pretty much a streamlined process. You have your inputs from the sensory, chemoreceptors, other things like that, which are processed in the DRG and just pass through to the pre-bots. And then you've got your VRG becoming more active as more sensory inputs come into that DRG, which turn on more switches to increase the activity of more muscles. And this happens in a very coordinated manner to ensure that we always have adequate ventilation to match the demands of activity. And that's also important to note that under resting conditions, under healthy conditions, kind of a nice slow graded wave of activity. We call it a ramp signal, and activity kind of gradually ramps up and then gradually decreases. I only bring this up because it kind of illustrates again how complex and how sophisticated our controlled breathing is. Because this pattern allows us to have smooth and controlled breaths. We don't have these sudden, drops, and increases in volume. It's a smooth transition to allow for the lungs to recoil, that all the breathing muscles to relax. And we often find sometimes when there is neurological conditions like TBI or stroke, some of this can be affected. Or if you may have heard the term agonal breathing, where you start seeing a loss of this smooth kind of ramping and ramping back down, that kind of illustrates kind of what we're seeing here. Now, also, um, it gets into this as well. Again, there are, again, muscles that become more active as demands increase. Again, the great thing about our breathing whole respiratory system, we've got a great reserve and a lot of redundancies to make sure that ventilation always stays preserved no matter the state or the task imposed upon the body. Um, and this is true even for our intercostals. We start seeing these gradually turn on more as demand increases, and they move further down, kind of in a rostrocaudally pattern of the contributions. This is done to ensure that we keep a mechanical advantage of those intercostals, um, as demand and expansion of the chest increases. So we call this term kind of neuromechanical matching. Basically, maintaining um, the ideal like pennation angle in a certain sense of the intercostals acting on the rib cage. So again, it just shows you again there's a lot of things that are coordinated very intricately, and we do it all to make sure that we match breathing at the lowest energy demand possible. Thing that my speech language pathologist will probably get a kick out of as well, is that not only is our like the activity on the chest wall very coordinated, there's even activities going on in our upper airways, or tongue specifically, even prior to breathing, right? So if you go back to this little chart here, looking at what we see before inspiration, we start seeing a little bit more earlier activity of our hypoglossal nerve. You may wonder, what is going on here? Well, essentially what happens is we have this we call hypoglossal. Um, oh, great. Thanks, Gary. We have this hypoglossal pre-inspiratory activity where essentially we've got airways, our muscles in our upper airways, which kind of contract, which keep the upper airways and the pharynx patent and rigid enough for air to flow in. We also have muscles that basically protrude the tongue forward away from the pharynx to allow air to flow in. So again, these happen in coordination before normal breath, and it's actually kind of where a lot of speech language pathologists come in and helping with breathing in particular, because the loss of coordination of the tongue muscles and that upper airway muscles, those pharyngeal muscles, are crucial ensuring keeping that airway patent and unobstructed. And we're actually finding a lot of patients who are diagnosed as like exercise-induced asthma may not actually have this. They may have we call it EILO or EILO, exercise-induced laryngeal obstruction, where this coordination is impaired and it creates kind of a wheezing sound. It's distinct, but also affects the amount of flow into the lungs. So it presents, clinically almost like an asthma, but it's nothing wrong with their lungs. It's loss of this coordination. Just showing that again, there's so many things that our body does very well coordinated, things that you don't even have to think about that we do every single breath, which is I think pretty fascinating. All right, so and we talked about this too, breathing patterns. Now, one thing I'll kind of get back into, I think sometimes we have this idealized kind of contrived view of what normal breathing patterns are. Now, let's tell you this right now that if you look closely at your breath, there is actually slight variability breath to breath, both in rate and in volume. No one does or really should breathe the same exact volume and rate, indefinitely. Like the heart, right? A little bit of variability actually reflects good robustness of the system. It reflects adaptability. It's a stochastic system. And we're often finding that there's in patients with lung diseases or any disease, we see a loss of variability, or we see very wide swings in variability. Okay, so your neural control of breathing, because it has all these different sensory inputs and different regulatory things, it's always making slight adjustments here and there, depending on the state. So again, we often view things again that breathing should be what occurs at rest. That may be good for resting conditions, may not be great for exercising conditions. If someone's in pain, right, and their sympathetic nervous system is kind of ramping up, which acts on the respiratory control centers kind of directly and indirectly, we're going to see a greater, excursion, maybe more activity of our scaling muscle. Like this is kind of what happens. Our breathing patterns are always adapting, and they're always adaptable. I'd say breathing variability creates adaptability, right? Healthy breathing is controlled variability, micro adjustments, adaptability. Okay, healthy systems, at a naked eye view, excuse me, look very steady. Don't look like there's much change at all. But if you look very carefully, you'll see a little bit of variability. And that's like if you look at someone balancing on a tightrope. Someone moving across a tightrope, may look like they're completely rock solid, not moving. But there's very little small micro adjustments are constantly occurring. Okay. And that stability comes from that ability to make those small constant adjustments around a physiological set point. And that example would be breathing. So good balance isn't about perfectly standing still. It's about making small, healthy adjustments. Unhealthy would be, chaotic, wide swings. We don't want that, right? But we don't want, rigid. So again, just thinking about again how we contextualize and operationalize what is a normal breathing pattern. Again, one, everyone's going to be a little bit different. Everyone's anatomy is going to be a little bit different. And, no one's breath is exactly the same breath to breath, right? Because of the way that our healthy respiratory control centers work. So again, healthy is controlled variability, micro adjustments. A rigid breathing pattern, right, was it falls because it's too brittle. It's not adaptable. Chaotic is not what we want. We don't want huge swings, but we want a little bit of variability that reflects our systems kind of working. All right, so getting back into how we, again, some of the kind of great things our breathing systems can do is coordinating and controlling with exercise. So if we look at, we talked about breathing is highly coordinated, even at resting conditions. This is especially true during exercise when demands increase. Now, what's kind of cool, like I mentioned, there are chemoreceptors, which are important, right? From which was what really the DRG is processing, but there's sensory inputs from everywhere, the lungs themselves, even, right? And even metaboreceptors in the breathing muscle. We'll talk about that later. We're also finding that there's this like tight connection between movement and ventilation. We find that even if you put someone, there's been studies that have done this under anesthesia and mobilize their legs, we start seeing respiratory rate and volume begin to increase because we think our body has this feedback mechanism from the mechanoreceptors in our limbs, our joints, and our muscles, which are also processed by a respiratory control center in order to match, again, breathing to demands. But we're also finding that there may even be a feed forward mechanism that even if you start thinking about exercise, we start seeing greater heart rate and ventilatory rate and more activity in the breathing muscles. So again, we think there's both feedback from those limb mechanical receptors, but also feed forward to prevent a lag in breathing. Because again, the goal of the respiratory center, okay, the respiratory system rather, is to ensure that we never have a lag, right? That we can always match breathing to the demands imposed upon it. And that's like the name of the game for the respiratory system, right? That's why we see greater activity during exercise, or even in states of disease where maybe the demands, the work of breathing increases. We see greater activity because our body will always try to maintain ventilation adequately to bring air in and to move air out, right? So again, and exercise is another example of this. So when we begin to exercise, this is actually another great paper from Dominelli in Advances in Physiological Education, one of the journals from the American Physiological Society. I'd also highly recommend downloading this one as well as a great resource to have if you were an educator, or even in practice too, because it really, I think, nicely illustrates the respiratory responses during exercise. A great paper, and this graph here specifically helps illustrate why we see certain changes during exercise in terms of ventilation, and it also gets into the role of the breathing muscles here and during exercise responses during to breathing. So break down the graph here again, going from left to right, resting conditions to maximal exercise. Okay. And then we have on here different variables plotted along this time or this continuum going in this direction. Okay. From rest to max. You can see here PaO2, PaO2, PCO2, which actually people don't realize doesn't really, it actually begins to decrease a little bit, SaO2, pH, and then but we're going to focus a lot on here. Frequency of breathing, FB, you can think of respiratory rate, VT, tidal volume, okay? And then VE here, which is ventilation. So VE, or V dot E, because it's a measurement taken during exercise, equals FB, okay, times VT, or tidal volume, okay? So frequency of breath times the volume of breath equals ventilation, the total amount in liters per minute, okay? Now, and at WB, worker breathing. We'll talk more about this later on in this presentation. Now, at the onset of exercise, you see a much more rapid increase in tidal volume, okay, compared to the frequency of breathing, okay? And this begins to continue on to roughly this pattern where the tidal volume increases a lot more. They're both increasing, but tidal volume increases much more than the frequency of breathing at the onset of exercise until we get to roughly about 40%, not 50% of maximal exercise, where it begins to rise more rapidly. It's kind of interesting. You can see the same thing with kind of heart rate and stroke volume, but that's neither here nor there. Now, people may wonder, like, why does that happen? Why is this super important? We have this normal pattern of breathing where the volume increases are at a much greater magnitude than the frequency increases. Well, it's because there's a principle called dead space ventilation. Okay. Now, again, we talk about minute ventilation. This is the movement of air, again, tidal volume times frequency of breath. Okay. And then we've got dead space ventilation and alveolar ventilation. Okay. In a healthy individual, okay, there is a kind of a fixed small volume in our lungs called the physiological dead space, or sorry, anatomical dead space, which is about 150 milliliters. Okay, about 150 milliliters. Okay, these are anatomical areas in the lungs that do not participate in gas exchange. Okay, which is like your extrathoracic airways, your primary bronchi. They don't participate in gas exchange. So whatever volume you bring in, there's going to be a little bit lost just to that. Okay. Now, alveolar ventilation, okay, is the actual volume of air that gets down from the upper airways into the alveoli, okay, down into the alveoli, which is a product of our minute ventilation, again, that tidal volume times frequency of breath, minus what we call dead space ventilation. So again, we have a dead space volume, VD, and then V dot D, which is dead space ventilation. Dead space ventilation is a product of that anatomical dead space, that 150, okay, times the frequency of breathing, which makes sense because the more breaths you bring in, okay, the more, loss to that anatomical dead space, which is fixed, okay? So the more frequently you breathe, the more that's going to be lost to that dead space. It's just not going to contribute. So this, I think this equation here will help illustrate the point of what I'm trying to get at here. So we got two patients here, with two different patterns of breathing during exercise. Pattern A, pattern B. They both generate the same minute ventilation, same actual amount of air coming into the lungs. Okay? But they accomplish it through two very different patterns. If you look at pattern A, 40, okay, liters per minute, their tidal volume is 1 liter. Okay? Meaning they're generating 40 breaths per minute to get to that 40 liters per minute. Well, we said though, again, dead space ventilation, okay, is VD times FB. So VD, again, is that fixed value of 150 or 0.15 liters. So 40 times 0.15, okay, equals 6 liters. So it means of the 40 liters per minute of air that we breathe in, 6 of that is lost to just dead space, does not contribute to gas exchange, meaning only about 34 is actually getting to the alveoli, right? So we lose about 6, right, in this example. But in pattern 2, let's look at this one. Again, same volume coming into the lungs, 40, but they accomplish it a different way. They're actually able to take a bigger breath, 2 liters, okay, double, which meaning they only have to breathe 20 breaths per minute to get to 40, okay? So for their dead space ventilation, they multiply 20, okay, times that anatomical dead space, which gives us 3 liters, meaning that only 3 are lost to that dead space, so 37 get down to the alveoli. So this illustrates how being able to generate bigger breaths, generating more volume, or creating more volume, allows us to breathe more efficiently by getting more of that air that we breathe into the lungs actually down to the alveoli and not just wasted, right, to dead space. And there's actually why a lot of patients with lung conditions where that anatomical dead space, right, this increases. So they actually breathe more frequently because they don't have as much volume and they breathe much less efficiently. So again, the ability to be able to generate that breath, so I actually had these illustrated, is where the breathing muscles come in, being able to generate, right, that bigger volume so we can keep, breathing more efficient. Now you may wonder, well, why don't we just increase the biggest breath from the very beginning? Well, one, we don't want like the more that we inflate our lungs, we talk about that elastic potential. So the more they're stretched out, the greater the subsequent effort is to reinflate them, to further inflate them. And it's in a non-linear increase too. So it increases exponentially. So we want to be able to increase, but in a controlled, coordinated way. We don't want to go from 0 to 100. And the other reason why this coordinated pattern, right, of breathing more efficiently, right, by taking those bigger breaths as we exercise, because the more frequently we breathe, we have more muscle contractions as well, which also increases the work of breathing. So that's why you might remember, I'll go through that part here quickly. The work of breathing stays relatively gradual. It increases as we breathe. But when we start seeing the frequency of breathing increase much more dramatically after that 46%, the work of breathing increases a lot, not only because the frequency of breaths, we have more contractions, we have greater flow rates, which increase turbulence in the airways. We also are stretching the lungs more, which also increases the work of breathing. So again, so we want to make sure we save those increases in frequency for later on versus very early in exercise. So again, this illustrates that this coordinated pattern of breathing is crucial in order to ensure that we can generate enough volume at the greatest degree of efficiency. And again, just looking at these different things that we see, we talked about this earlier, the changes in the role of those muscles, and it's illustrating again how those accessory muscles become very important to this because they're what allow us to generate those bigger volumes to keep breathing more efficient. Now, the last thing we'll talk about as well in terms of exercise responses is this respiratory metabolite reflex. So, like I mentioned, the goal of your body is always to preserve breathing, really, no matter what. Now, in some instances, the breathing muscles can get fatigued during exercise, notably. Okay. Once that happens, you actually have sympathetic nerve afferents called metaboreceptors, which are these group 3 and group 4 afferent fibers, which detect metabolites building up in the muscles because they're fatiguing. Okay. That causes them to send signals to the brain, all right, to the sympathetic nervous system, basically saying, hey, our breathing muscles are fatiguing. We're sensing this buildup of metabolites. That causes a global sympathetic discharge, efferent discharge, which causes vasoconstriction. That's what the sympathetic nervous system does to the vasculature, diffusely. Okay? Which causes vasoconstriction globally. But because not only are those metabolites activating, right, these nerve afferents, they're also vasoactive and cause dilation in the vascular beds of the breathing muscles. And what that does is it lowers the resistance or lowers the pressure in those in those vascular beds of the breathing muscles. So when the summative effect is you have a global vasoconstriction and a local vasodilation in the vascular beds of the breathing muscles. So you have a shunting of blood from the periphery to the breathing muscles to preserve breathing. Because, like I said, your body will go at great lengths to always maintain breathing to the demands imposed upon it, and even stealing essentially from the locomotor muscles. So sometimes patients can experience dyspnea and shortness of breath at extremes of exercise and leg cramping, especially in patients of heart failure, who may be more susceptible to this fatigue of the breathing muscles. We're also finding it may be possible at extremes of exercise intensity where these breathing muscles get fatigued and this reflex kicks in. But that's still kind of questionable. It's up for debate. But that's another contribution of the breathing muscles in terms of the exercise responses and your ability to tolerate exercise. Now, last thing I'll talk about is just getting into what actually do the breathing muscles work against. Again, dyspnea and the work of breathing. Now, the work of breathing, you can think of as the energy consumed by the respiratory muscles throughout the respiratory cycle. The work of breathing consists of both elastic and resistive components. Okay. Compliance or those elastic components kind of dominate during quiet breathing, whereas airway resistance kind of dominates during high demand, like exercise. Now, some things there's any I don't even have all of them included, even like the gas density and stuff like that can also affect the work of breathing. But obviously, airway resistance, if that increases, the work of breathing increases. If lung compliance changes, we have very stiff lungs or excessively compliant lungs that will also increase the work of breathing. And then chest wall compliance, right? Obviously, if chest wall compliance decreases, work of breathing increases, and ventilatory demand, right? As we have higher minute ventilation, we have more rapid or more turbulent breathing. We also have more contractions of the breathing muscles per cycle, which also increases the work rate. Now, the great thing for us is under normal conditions, we operate at a high degree of efficiency. We have a high reserve and force generating capacities to overcome that work of breathing. But it's a supply demand imbalance sometimes, where if we have either excessive work of breathing relative to the force generating capacity of the breathing muscles, or if the force generating capacity of the breathing muscles decreases, like we have here, either if this increases or if this decreases, we create an imbalance, which can lead to this perception of shortness of breath. You can think of this conceptually as if you're like lifting a muscle or lifting like weights with your doing a bicep curl, and you get closer to your max, you get fatigued, right? Same sort of thing with our breathing muscles. If we work too close to their margins are going to experience fatigue. For the breathing muscles, that perception is dyspnea. Now, dyspnea can be caused by a lot of other things, but this is one mechanism for it and explains the symptoms that patients may experience with weaker breathing muscles when they begin to exercise, when those demands increase, or even at rest, or if they have excessive changes to the work of breathing at rest. An example of this, obesity, is a population I work with where there is huge reductions in chest wall compliance, reductions in lung volumes, which decrease airway caliper size, which increase airway resistance. So in obese patients, they have a threefold increase in the work of breathing, which makes even basic tasks sometimes very challenging because the work the breathing muscles have to work against is higher at a three time rate. So again, just an example of how these things can kind of play in. So, and why patients with obesity, for example, get very short of breath, even if they may not have asthma, um, uh, may have normal, completely healthy lungs, but get very short of breath because of the demands imposed on those breathing muscles. From the changes of chest wall compliance and airway resistance that occurs with smaller lung volumes. So, and why they may get really, really short of breath even with basic activities. So, in summary, I want you guys to always remember the lungs, airways, diaphragm, intercostals, all those muscles and the pleural system kind of work together in an integrated system. I think we need to move away from thinking of just the diaphragm for the breathing muscles. There's a lot of other muscles that contribute, right? We wouldn't do that for locomotion. We wouldn't just say the quads. It's the hip flexors, it's the calves, right? It's the trunk muscles, right? All work together in sync, right, to perform a task. Breathing is no different, and they're just like locomotion is controlled by a central pattern generator. And the relative contributions of those different muscles changes based on the demands imposed upon it. Just like when we switch from a walking gait to a running gait, right? That changes. Just like we do moving from a resting breathing pattern to a running breathing pattern. Those are normal things. There's a lot of other muscles, a lot of other things that work together to create, to maintain ventilation, right? Again, pressure gradients drive ventilation, and that's kind of where the breathing muscles really shine here. They're the ones that create that pressure generation and help mitigate or help manipulate the flow, especially during exercise responses. And again, getting away from this idealized view of what a normal, perfect breathing pattern is. The best breathing pattern is the one that meets ventilatory demand with the least amount of work. And again, it's going to be context dependent. You want greater upper chest wall expansion in scaling activity if the demands, of breathing require it, right? It's all context dependent. Now, we're looking for some great documents to kind of help guide you on this. Some great stuff from the European Respiratory Society. And of course, as Jenny mentioned, we have the ACSM guidelines, which kind of go through operationalizing how to perform testing and training, which I help author a part of it. So with that, I know we got right to the margin. So I apologize for going over a little bit about staying on if you guys have questions.
Thank you so much, Dr. Severin. That was very comprehensive, and I think you gave everybody a little bit. There are many, many disciplines in the audience. For those of you who are asking about continuing education credit, you can check in with your respective associations. I'm happy to provide you with a certificate of attendance. My email is jenny@emst150.com. I put that in the chat for you. Someone is asking if we could see the previous article slides, please, Dr. Severin.
Previous article slides?
Yes. The references
this here?
Yeah. These, yes.
Yeah.
Yeah. And this presentation is recorded. It will be available for you on demand. It will be both on our website, on the healthcare professional side of that website, which is free to access, as well as on our YouTube channel. So this is for you to have as a resource going forward. Thank you, everybody, for being here. Thank you, Dr. Severin, for everything. If there are any questions that we missed, or if you think of something, please feel free to reach out to us. We are so happy to support you.
Great.
Thank you.
Any questions or?
I think we'll save, if anybody has questions, they can email us.
Cool, cool.
But you have lots of thank yous.